on high impact HIV prevention. Today's material really will focus on linkage to care and treatment adherence and treatment as prevention and how those fit into the new high impact HIV prevention approach. If you missed the first webinar in this series, it was an overview of high impact HIV prevention, and it is available on our website. We'll give you a link to where you can find those resources a little bit later in today's webinar. And then the third part in the series is going to focus on high impact HIV testing, and that'll be coming up on July 11th. We'll give you more information about that as we close out today's webinar. So today's webinar is presented by Capacity for Health. We're a capacity building assistance program of the Asian and Pacific Islander American Health Forum. We have offices in both San Francisco and DC. And we're funded directly by the Center for Disease Control and Prevention to provide free capacity building services to organizations that engage in HIV prevention. And we do work in a variety of different content areas. We do work around all of the sort of organizational needs like strategic planning and board development and fund development. We also do work specifically around evidence-based interventions and public health strategies, which is one of the things we're going to talk quite a bit about today, and we've been talking about quite a lot as part of this series. And we also do work around monitoring and evaluation and helping organizations to understand what's working and not working in their programs. So all of our services are totally free. We do webinars like this. We also work individually with organizations to help coach them and provide specific tailored materials. We also do in-person trainings, and we'll have more information at the end of today's webinar about how to contact us if you'd like to request further capacity building or further technical assistance. So just a few housekeeping pieces of information before we get into our content. You've all been muted automatically. We will have an opportunity for you to ask questions. You can chat them in your questions feature, which is in the lower right-hand corner of your webinar control panel. You also will have an opportunity to raise your hand to ask a question live if you would like. To do so, we can only unmute your audio if you've entered your audio PIN, and that's only if you're on a telephone that we need that. But if you are on a telephone, please make sure you've entered your audio PIN if you want to be able to ask questions live. Also, if you have multiple people around one computer screen, it's great if you can just use that questions feature to chat in your contact information, and that way we can make sure to include you on the follow-up, which will include slides and a link to other materials associated with this webinar. And finally, today's webinar is being recorded, and the recording will be available on our website. And again, we'll talk at the end of the webinar about where you can find further resources, and the recordings and the slides and stuff will all be posted probably by the end of today. So I'm really excited that we have Shelley Facente joining us again. She was here for the first part of the series, and she'll be back again for the third. Shelley has been working in HIV prevention for nearly 20 years and has done a lot of work in both clinical prevention as well as behavioral programs, and done a lot of program planning and management as well as evaluation. And she and I have had the opportunity to work together on a number of projects, but it's been really a delight to work with her over the last several months as we've developed this high impact HIV prevention series. So I'm going to give Shelley an opportunity to introduce herself if there's anything else she would like to say by way of introduction.
Thanks, Sonia. I don't really have a whole lot more to add. I just want to say welcome, and I'm really excited to be part of this series. It's really interesting, especially to hear from what people all around have to say about these topics. It's a really good opportunity, I think, to connect with other people. So it's great. Thanks.
Well, thank you, Shelley, for joining us again today. We're really excited to engage in this conversation about high-impact HIV prevention and what it really means for our programs. So just as a little bit of an overview of what we're going to be covering today, we're really focusing on different components of high-impact HIV prevention. So today we're really wanting to explore the emphasis that's being placed on supporting linkage to care for people with HIV, as well as thinking about this concept of treatment as prevention and what that means for some of the prevention programs that we're currently engaged in. So in terms of our specific learning objectives, we're going to really be talking about the importance of linkage to care and treatment adherence and how they fit into high-impact HIV prevention. Also looking at some of the specific interventions and how we can integrate those interventions either into existing testing and case management programs, or looking at some of the new proven effective interventions that the CDC is promoting, particularly now as part of high-impact prevention. And finally, really on a practical note, we want to make sure that as folks leave this webinar, they know where to get more information, more resources, and how to then think about how they might want to approach linkage to care and treatment as prevention and treatment adherence within their existing HIV prevention programs. So our agenda for the day, really we're going to be focusing on the importance of linkage to care and barriers that impede linkage to care. We'll talk about the effective interventions for linkage to care, and then we'll move on to talk about treatment as prevention and some effective interventions around treatment adherence. And as I said, we'll end with some further resources as well as information about the rest of this series and where to get the materials that were developed as part of this High Impact HIV Prevention series. So we always like to start our webinars hearing a little bit about who you are and what you already know. So you will see a quick poll popping up on your screen right now. If you can actually go ahead and take a minute and tell us just a little bit about what you already know about ways to address linkage to care, perhaps how you're already doing this as part of your HIV prevention work. You'll see there four options up on your screen. And go ahead and just poll in your thoughts or ideas or knowledge at this point. We'll give you just a second to do that. So let's go ahead and close out the poll and see what people had to say and what folks already know. So it looks like most of you were almost unanimous on all of the above. It's great. So yes, that is, we are going to be talking actually a little bit about all of these methods today in terms of linkage to care, and we're going to talk about ways to integrate linkage to care into work that we're already doing, whether that's HIV testing interventions or case management interventions. Obviously, linkage to care is a piece of prevention with positives, and treatment adherence and treatment as prevention are a piece of that as well. And there are some great structural interventions that we'll talk about too. So thank you all for participating. There'll be more opportunities for you to poll in answers and chat in response to some questions as we go. We do try to keep these webinars as interactive as possible given the format of the presentation. So I'm going to go ahead and turn it over to Shelley, who's going to start talking us through sort of the importance of linkage to care and high impact HIV prevention.
Great, Sonia, thanks. So we're going to start first with a quick review of what we're calling the high impact approach. And Sonia's already talked about high impact HIV prevention, and you may have even seen the first webinar in the series. But for those of you who haven't, we thought it made sense to do a quick review here, and then we'll talk about why linkage to care is such an important part of that. So high impact HIV prevention is the Center for Disease Control and Prevention, or CDC's, new approach to reducing HIV infections in the United States. And it's designed to maximize the impact of prevention efforts for all Americans at risk for HIV infection. So that includes gay and bisexual men, communities of color, women, injection drug users, transgender women and men, youth, basically anybody who's at risk for HIV infection. And high impact HIV prevention prioritizes interventions that are cost effective, that reach a large number of people, have been thoughtfully chosen for their impact with a particular population or geographic area. So they're really it's honing in on the populations that need it the most and making sure that the interventions that are used really make the most sense possible for that population in that area. And one of the most important components of any high-impact HIV prevention strategy is strong support for linkage to care. So that's why this webinar is part of this series. So more information about high-impact interventions are available at CDC's website, which I'm hoping you can see. There you go, which is www.effectiveinterventions.org. So if you haven't already been to that website and looked at it, there's a lot of good resources there all about high-impact HIV prevention and the interventions that CDC is really emphasizing under this approach. So it's an important project. So for a more comprehensive overview of high-impact HIV prevention, you can see part 1 of this 3-part series, which is recorded and available on the Capacity for Health website. And there's an information sheet, which is a document that you can see. And there's also an online training module there's a few of them actually that are available on Capacity for Health's online resource library that provide a comprehensive overview of high-impact HIV prevention. So hopefully all those are helpful for you. Okay, so now let's really get into the meat of linkage to care. Let's start with why linkage to care matters so much for people with HIV. So if a person finds out that they have HIV before they're noticeably sick, and if they're then connected to important resources and supports, they will have the best opportunity to make healthy choices that help them stay healthy for longer, improve their overall quality of life, and even significantly prolong their lives. So this is obviously really important. HIV-positive people may have a number of other areas where linkages are needed besides just medical care, which is part of it. So these could include peer support, as I just said, basic medical care, HIV medical care, also housing, substance use treatment, mental health services, partner services, and all of those things are important linkages. So you or your staff may be able to support your clients with any or maybe all of those linkages, or if not, if they're linked to HIV medical care, hopefully their medical provider would be able to facilitate linkages like these as well. So sometimes it's just one linkage to a really solid source of care, and then those people have the connections to get people whatever other kinds of linkages they need. So that's important. Let's talk more first about what linkage to medical care, HIV medical care, really involves, as this is an essential component of linkage to care services. So linkage to HIV medical care is an essential service that all HIV-positive individuals really should have access to. Receiving care from an HIV specialist can provide HIV-positive individuals with the best information about all of their options, as well as essential knowledge of how HIV may be impacting their bodies and what they can do to support their overall health and wellness. And most importantly, linkage to care means a person with HIV is able to find and build a relationship with a good medical provider before they get sick and need more advanced care. And this is really important. When someone is really sick, they have more advanced disease, they really need more urgent care, that's not a really good time to be finding and building a relationship with a provider. So doing that early when people are feeling generally healthy is ideal, so that later on, if they need that provider, they already have that relationship. And then once linked with a medical provider, they're able to work with that person to monitor their CD4 counts and viral load to see how the virus is affecting their body and really understand what that virus means for them specifically. And for many HIV-positive individuals, HIV medical care also includes conversations about possible antiretroviral medications. Since the introduction of highly active antiretroviral therapy, or sometimes it's known as HART or ART or ART, in 1995, HIV treatment has dramatically improved. And there's now numerous HIV medications available. They're generally simpler and less have less side effects and less impact on the body than was previously true, for sure. So in fact, in March of this year, with 2012, the U.S. Department of Health and Human Services released new guidelines for HIV treatment that say essentially that everyone is recommended to begin antiretroviral therapy as soon as possible after infection, regardless of their CD4 count. So this is a pretty huge shift in the way that we've dealt with antiretroviral medications for HIV. But many people living with HIV experience multiple barriers to engaging in routine medical care, even if they know it's important, and that's something I'm sure all of you are familiar with. So just as a review, these include maybe not knowing any high-quality HIV care providers, lack of transportation to a provider, having denial about HIV status, or maybe just unwillingness to confront status and regularly seek medical care at this point, fear of stigma from seeking HIV medical care, lack of health insurance, or just the inability to negotiate the healthcare system to obtain free or low-cost care. So sometimes it's just a navigation issue. Concerns about the side effects of treatment when they're still feeling healthy, fear that if they connect with medical care, then that'll instantly mean medications, which will instantly make them feel sick and not wanting to go down that road quite yet. And then competing needs such as drug use, poverty, homelessness, food insecurity, things like that that can make it really difficult to prioritize HIV care. And I'm sure you've experienced a lot of these with people that you're working with. So linkage to care programs, interventions like we're talking about today, really aim to help people living with HIV address all of these types of issues and reduce barriers to care so that it's easier for them to get the care that makes sense for them. So let's take a minute before I keep going to hear what you have to say. We really want to hear what other barriers to care you've noticed for your HIV-positive clients that I didn't just mention in that list that I gave there, because it certainly wasn't entirely comprehensive. So we'd love it if you would chat in your responses using the question feature, and hopefully that's clear to you. But it's also a good time to remind you that even if you're not answering this particular question, this is a really good time that you can chat in questions now, or you can do it at any time, really, using this question feature. Or if you prefer, you're welcome to raise your hand through the GoToWebinar interface here and ask your question live. So we want to make sure that we take a break here for people to have some questions asked. Sonia, do you want to review some of these things that people are chatting in? Or would you like me to do that?
So I think you should all actually be able to see in your window what some of the other participants on today's webinar are saying in terms of barriers, but people are talking a bit about immigration status, lack of specialist cultural and linguistic competency of providers in their geographic areas. That's a really important one to be talking about. Lack of HIV specialist providers, language barriers, mental health issues, transportation. So we'll go ahead and just let folks continue to post through the chat feature, and you guys should all be able to actually see that. I'm not seeing any specific questions coming in yet, but we will pause again to answer questions in a little bit.
Great. Thanks for that. Okay, so keep chatting those things in, but I'll keep going in the webinar, and then if there are questions, you can, like Sonia just said, you can ask those too, and we'll take some time in a little bit to go over some questions as well. Okay, so now let's talk about some of the interventions in which linkage to care plays a big part. So first we'll discuss linkage to care as part of HIV testing or ongoing case management programs integrated within those other types of programs, and then we'll discuss additional strategies to improve linkage to care that are more specifically set up for linkage to care, including patient navigators, use of social media, and then the ARTAS intervention, which you may know about and which we'll talk about a little bit. So first we'll start with HIV testing. One of the major public health strategies to reduce HIV infections is HIV CTR, or counseling, testing, and referral. And specifically the R, or referral, part of the intervention is intended to include linkage to care, especially when someone tests positive. So ideally referrals and linkages would be available for everyone, but certainly when someone tests positive, linkage to medical care is a really critical part of most CTR programs. And in addition to typical HIV CTR programs that you might be aware of, in 2006 the CDC released revised recommendations for HIV testing in healthcare settings. So this looks a little different. These revised recommendations aim to make HIV testing a routine part of all medical care. And they really work to allow people to opt out if they don't want to test, rather than opt in by asking for an HIV test. So the default is to just include HIV testing as part of a routine medical care for everyone. And counseling isn't required with this type of testing under these recommendations, but linkage to HIV-specific medical care for all patients who test positive is a really important part of the recommendations. So again, linkage to care is really critical here. After a person tests HIV positive, their HIV test counselor or medical provider should be offering to help actively link them to medical care immediately. And this is regardless of the testing setting, if it's a medical site, if it's a community-based organization doing a CTR program, whatever it is, the active linkage to medical care is really important. So this doesn't simply involve giving them a phone number to call, but rather actually calling to make an appointment, or helping them get to the appointment by arranging transportation, maybe even accompanying them to the appointment, or or following up with them to make sure the appointment went well. So calling at some later date, saying, did you go to that appointment? How was it? What worked? What didn't work? What can we do to support you? All those kinds of things. So whatever is most appropriate for the client. It's really meeting the client's needs, but being very active in helping them engage in medical care. And not all clients will be ready to immediately access medical care, and that's okay, but it's up to the counselor or the medical provider to really make sure they have all the information and support that they need to access medical care as soon as they are ready to do so. So it's really about having the information out there, having the support available, and then really supporting them in whatever makes sense for them at that moment in their learning that they have HIV and taking all the next steps that go with that. So along with this idea of active linkage, it's really also increasingly more important that referrals are documented and linkages are documented. So this means not just noting that a referral was made to medical care or any other kind of linkage, but really being sure that the client actually attended their first medical appointment. And so in other words, making sure that that linkage was successful. That's really important. And some ways to do this include actually accompanying people to their appointment. Obviously, if you go with them, you know that they went. Another option is to give them a form to have their clinician sign and then return to you at the next visit so that you know that the medical appointment that they went. Another one is just following up with them after the appointment to know that they went, like I mentioned before. And also you could have them sign a release of information form so that you can follow up with their medical provider directly to see whether they attended the appointment. So some people prefer, no, I don't need you to call me, I don't want you to follow up with me directly, but here, I'll sign this paper and then you can just call my doctor and get whatever information you need. So this really isn't a matter of more paperwork. It's a way to learn what methods of linkage to care are working well and ensuring that clients are really getting the care that they need. Sometimes with all of the things we have going on and all the paperwork we have associated with so many things, some people feel like, oh, this is just one more thing that I have to track this so that I can check the box. But really, it's about making sure that this really vital step for people with HIV is really being done successfully and that we're focusing on the things that are most successful and not focusing as much on the things that don't seem to be working so well. So that's a summary of HIV testing and how linkage to care works with that. The next piece is through case management. So another way that HIV positive clients are very frequently linked to care is through ongoing case management programs. And a case manager might help link a client to a wide variety of needed services. So this is like that list before: peer support, HIV medical care, basic medical care that may not be specific to their HIV, substance use treatment, mental health services, housing, all of those types of things. That's very typical for case management. And like we discussed when talking about linkage to care as part of HIV testing, it's really important that linkage to care be an active process rather than a passive process within case management. It's generally not considered to be enough to simply offer referrals or give clients names and numbers of available support services and then feel like that's the linkage piece. So when case managers provide linkage to care, similar to an HIV test counselor or a provider who's offering HIV testing, they can help make appointments, arrange transportation, accompany the clients to appointments. But sometimes it also goes a little further with case management. So things like helping clients think about questions they need to ask their providers or helping them learn to advocate for themselves with service providers so that they can really get what they need to get out of that medical appointment, really supporting them that way. Or not just medical appointment, any kind of appointment. And then when case managers are linking clients to HIV medical care, specifically, the support they provide can also involve helping clients to understand what will happen in a medical appointment, to manage their various medical needs or medical care follow-up, and to reinforce and explain the information being communicated at medical appointments, even to help clients come up with a system to remember to take their medications on time. There's just so many things that can be so overwhelming for people going to meet with a provider about something, about anything really, but specifically with HIV, that it's really important for them to have an advocate of some kind to help them really make the most of those medical appointments, and sometimes that can be a case manager or someone the case manager links them to support them with help. So one very common intervention for ongoing case management is CRCS, which stands for Comprehensive Risk Counseling and Services, and at one time was referred to as Prevention Case Management. So if you haven't heard the CRCS name, you might know PCM or Prevention Case Management. So now, though, unlike back in the days of prevention case management, the focus of CRCS has really expanded beyond high-risk HIV-negative people, and the CDC says, as this quote reads here, priority for CRCS services should be given to HIV-infected persons who are having or are likely to have difficulty initiating or sustaining practices that reduce or prevent HIV transmission and reinfection. So essentially a core element of CRCS then is ensuring that all people with HIV are linked to HIV medical care as well as other needed services. It's really clear that that's a major point of CRCS. So related to that, another effective intervention that incorporates case management with a focus on linkage to care is CLEAR, which stands for Choosing Life, Empowerment, Action, and Results. CLEAR is a one-on-one counseling intervention, and you can find out a lot more information on CDC's website about this particular intervention if you haven't already heard about it. It's a one-on-one counseling intervention that supports HIV-positive people to improve their health and to reduce risk of HIV transmission to others. So it's often used by people as a structured curriculum for CRCS. It's really connected to case management in that way for a lot of people. So it's a multiple session intervention, and it has 5 required core skills sessions, and then there's 21 optional menu sessions depending on the needs of the client, and then a wrap-up session. And 6 of these sessions focus on issues specifically related to linkage to care, although many of the core skills sessions relate to a person's ability to remain engaged in high-quality medical care. So almost all of this is related in some way. A CLEAR counselor could provide support in sessions including attending healthcare appointments, understanding my medications, motivation for change, wanting to stay healthy. Those are just some of the session titles that are part of the CLEAR intervention, so you can see how they really relate to what we're talking about. So as I said, for more information about CLEAR, you can go to the effectiveinterventions.org website. It's one of the effective behavioral interventions that is listed on the website, and there's a lot of descriptions, resources, and tools on the website, in addition to a link for trainings for CLEAR. So if you want to use CLEAR, people go to specific trainings, and you can get those through that website. Okay. So another strategy for improving linkage to care is through patient navigators. Patient navigators are used in many healthcare fields, so you may be familiar with them already. For HIV care specifically, patient navigators assist people living with HIV to access care resources and to develop effective communication with their healthcare providers. So these navigators might be professional staff or trained peers, but they provide practical and emotional support to people with HIV and help them understand the HIV care options available to them. So like I was saying before, a case manager might play some of this role, but it might make more sense to link a client who really needs this kind of support with a patient navigator who's specifically set up to really help them navigate the medical system and their medical appointments and what they need to get out of their providers. So essentially their job is to hold the hand of someone who's HIV positive and really help ensure they get high quality medical care as often as they need. It's a really good strategy. Another strategy to directly support linkage to care for people with HIV is social media. So research has shown that peer referrals and other social networking strategies are extremely effective at improving linkage to care. We all know that more and more people communicate through various forms of social media. Even people who don't have smartphones or regular computer access often have a Facebook account or use Twitter or know about it, know how to access it when they go to a computer lab or a computer at a library. It's really important these days. And so strategies that utilize social media platforms to share information and increase peer support for HIV care providers are a really effective piece of a comprehensive strategy to improve linkage to care. And you're starting to see a lot more requirements when people are developing interventions or asking for funding that they come up with ways to include social media in their interventions and what they're doing. So it's really growing awareness of how important it is to use social media in what you're doing. And then the final effective intervention we're going to discuss today that helps to increase linkage to care is ARTAS. So ARTAS stands for Antiretroviral Treatment and Access to Services, and it's a proven effective behavioral intervention similar to CLEAR, and it's specifically designed to increase linkage to care for HIV-positive individuals. That's really the whole point of ARTAS. So it's an individual level intervention that's intended for any person recently diagnosed with HIV. That's the idea. The goal is to link these recently diagnosed people to medical care very soon after receiving their HIV-positive result. This really rapid linkage is the goal behind ARTAS. So ARTAS relies on an effective working relationship between a linkage coordinator and newly diagnosed HIV-positive clients. This relationship is really important. And it lasts for up to 5 client sessions or until the client is linked to care, whichever comes first. As I said already, the strong relationship between the linkage coordinator and the ARTAS client is really the foundation of this entire linkage to care intervention. So rather than looking at the challenges the client faces in linking to care, as we did earlier, ARTAS really focuses on the positives by conducting a strengths-based assessment and encouraging each client to identify and use his or her strengths, abilities, skills to link to medical care and accomplish other goals. And that's one of the things that's so great about it, is that it is so strengths-based. And along with the strengths-based approach, ARTAS really uses a client-driven approach as well. So the linkage coordinator's job is actually to help the client identify and pursue his or her own goals, and specifically to work with them to develop a step-by-step plan to accomplish those goals. It's really driven by them and what they want to achieve. And specific ARTAS activities are really intended to be tailored to each individual client. The basic ARTAS structure involves, as I said, conducting between 1 and 5 structured sessions with each client. It also really involves meeting each client in his or her environment and outside the office whenever possible. It's very different from the type of intervention where someone would come in on a periodic basis to meet with a counselor in an office at an organization. And this is really meant to come to them and meet outside of that kind of office setting. It also involves coordinating and linking each client to available community resources. And this could be formal, like housing agencies or food banks, but also informal, friends, support groups, spiritual groups, whatever it is based on their need, so that they're really connected to the community resources that are out there and mean something to them. And then the fourth piece is really advocating on each client's behalf to link him or her to medical care and other needed services. Really, advocacy is a really important part of this intervention. Okay, so that's the summary of the interventions that are really emphasized under this high-impact HIV prevention approach. And before we move on to the next part of the webinar, which is about treatment as prevention, we wanted to take another break to hear from you again. So this is a good time to ask any questions that you have as well, using your question feature, but also chat in your responses to this question using that same question feature. So the question is, what linkage to care interventions have you found to be most successful with your clients? We'd really like to hear from you because we know you have a lot of experience in this area, and it's always good to hear what people have to say.
So while we let folks chat in, we do have a couple of questions, specifically about different terminology and the differences between different kinds of case management. So we had a question about the difference between a prevention case management focus versus the Ryan White medical case management, and just because there's a lot of terminology, just say prevention case management, or PCM, is sort of the language that we used to use before we started talking about CRCS, and all three of those actually, prevention case management, Ryan White medical case management, and CRCS, are often more of long-term case management programs. And one of the differentiations between some of the newer interventions like ARTAS is that linkage to care case management or linkage to care interventions can also be very short-term. So ARTAS, for example, has a very short-term focus around sort of immediate short-term goals in linking to care. And one of the components of shorter-term case management can be then to also link people to longer-term or more ongoing case management programs like Ryan White medical case management or prevention case management or CRCS programs. We also had a question about the difference between a case manager and a patient navigator. And again, just in terms of language, the term case manager would often refer to somebody who's providing support potentially around a wide array of different issues in somebody's life, whereas a patient navigator is really providing support just very specifically around the client accessing medical care. So patient navigators can help clients to navigate the systems of healthcare, but also can be supporting and advocating that relationship building. But it really is very specific to accessing medical care, as opposed to case management, which can focus on many, many different topics. Maybe we'll just take one more question right now, and then again we'll take a break for questions later. We're getting a lot of questions, and we're so glad that you are all really engaged. We'll try to type back responses to your questions as well as come back to a few more questions later. Somebody asked whether patient navigators can also be client volunteers, and the answer to that is absolutely yes. Often patient navigator programs are peer-based. And peer support can be a really key issue in helping folks to link to care and overcome some of those barriers to care. And the follow-up question is, are there specific trainings around using client volunteers as patient navigators? I know of many programs who are doing this. I don't actually know right now of programs who are training on this, but I will try to look up some further resources and email a response to you as well about that. So let's go ahead and move on. I know we have a bunch of content we still want to cover, but we will try to come back to some of your other questions, and I'll try to type in some answers to your questions as well.
Great. Thanks, Sonia. Okay, so now we'll go to the second major part of the webinar, which is treatment as prevention. So in addition to all the ways that linkage to care supports the health and wellness of HIV-positive individuals, it can also help prevent new HIV infections. And we don't always talk about this. When HIV-positive individuals know their status and are linked to HIV medical care, they can make informed decisions about accessing HIV medications. And taking HIV medications can reduce viral load, which has an impact on the health of the person taking the medication, but it also reduces the possibility of HIV transmission to others. And this is something research has really shown us. Research has clearly shown that people who are adherent to their HIV treatment, which in other words that they take it as it's prescribed, and have a suppressed viral load, sometimes called being undetectable. If they're taking their HIV treatment and they end up with a suppressed viral load, they're far less likely to transmit HIV to others. And one recent major study from Africa demonstrated that suppressing viral load in an HIV-infected person can decrease the risk of HIV transmission to uninfected sexual partners by as much as 96%. So this is a really important HIV prevention intervention. And within the new High Impact HIV Prevention approach, there's an increasing emphasis on treatment as prevention. And so basically this is a phrase that means what it says. It recognizes that HIV treatment is actually a form of HIV prevention because in addition to improving the health of the person taking the treatment, it reduces the chance that that person will transmit the virus to someone else. So treatment as prevention is becoming a phrase you may hear more and more. This is a chart adapted from information published by Irene Hall and colleagues in the Journal of the American Medical Association in 2008. And it shows what's sometimes called the treatment cascade. So basically you can see that there, in the first bar there are almost 1.2 million Americans who are living with HIV, or were at the time this was published in 2008. Of only 942,000 or so of those actually know they're HIV positive, so that's the second bar, HIV diagnosed. And of those, only about 3/4 are actually linked to care, as you see in the third bar. And then only slightly more than half are on antiretroviral therapy, and even fewer have a suppressed viral load in the last bar there. So when it comes down to it, what you see here is only 28% of HIV-infected people in the United States have a suppressed viral load. And since suppressing viral load is one of the best ways to reduce HIV transmissions, this is why interventions to link people to care and help them adhere to treatment are really becoming recognized as an extremely important part of HIV prevention. We really want to bring that last bar up to be very, very close to what the first bar is. That would be ideal, is that it would be blue all the way across the chart. So treatment adherence can be challenging for anyone. And there's a few reasons that a person might not adhere to their treatment regimen, and it's important to review that. Those reasons can be planned or unplanned. So some examples are forgetting to fill or refill a prescription, suddenly just not having the pills to take even if you want to. Another one is stopping a medication before the full prescription is taken, taking more or less of a medication than is prescribed, or even taking a dose of medication at the wrong time or with the wrong food. These kinds of things, sometimes they're totally inadvertent, people don't realize it, but it can make them feel very sick, which can affect their ability or their sort of interest or ability to take more of the medication, or it may just be getting into a schedule and following directions, any of those kinds of things. So to help people with HIV adhere very closely to their treatment regimens, there are a number of effective interventions. And we're going to review a bunch of those today. So there are at least 8 interventions that have demonstrated efficacy in reducing HIV viral load or improving HIV medication adherence behaviors. So these are referred to as treatment adherence interventions or medication adherence interventions. We're going to go through some of these quickly now and share the highlights of the interventions so you know a little bit about how they work, but also some results from the studies that originated these interventions. So the first one is ATHENA, which stands for Adherence Through Home Education and Adherence Through Home Education and Nursing Assessment, ATHENA. So the ATHENA intervention lasts for 12 months, during which HIV-positive patients receive up to 24 home visits from a nurse and community worker pair, and the focus is really on supporting medication adherence. ATHENA was found to significantly improve patients' medication adherence. In the original study that kind of launched this as an intervention, 31% of ATHENA participants were greater than or equal to 90% adherent in their regimens, compared to only 22% of the control group. And this was 12 months after the intervention. So a full year after the intervention, 31% of ATHENA participants were at least 90% adherent and only 22% of the control group. So it's really an effective intervention. The second intervention is DART, DART for drug users. So DART stands for Directly Administered Antiretroviral Therapy. And you know, you have to have an acronym. Almost every intervention has an acronym. I think it's a public health rule somewhere. You've got to come up with a good acronym. So in the DART intervention, DART for drug users, participants are provided with a pager that's programmed to remind them to report to a mobile community healthcare van, like the one you see here in this photo, to take their medications with a DART specialist. It was provided for 6 consecutive months, and then in the 6th month, patients are trained to package and self-administer their own medication so that when they leave the formal program after 6 months, they already have the skills to keep up with adherence on their own. And then they're monitored for 6 additional months to ensure success with adhering to their regimen. So for 6 months, they're paged and they go to the community healthcare van and they take their medications with a DART specialist. Then they're trained to do it themselves as the 6 months comes to an end. Then they do it themselves, but their support and they're checked in, the DART specialist checks in with them for 6 months to make sure it's going well before they go off on their own. So in the original study, the DART intervention also led to a significant reduction in viral load. So 71% of participants in this DART intervention achieved a viral load of less than 400 copies per milliliter of blood, compared to only 55% in the control group. This worked really well to suppress viral load. The third intervention is also DART, but it's DART in methadone clinics. So it's the same DART, it stands for the same thing, but this one's focused in methadone clinics. So in this intervention, each morning that patients attend a methadone clinic, a nurse or a medical assistant observes them taking their HIV medications in a private room that's distinct from the methadone dispensing window. So they go into a private room, and DART is provided for at least 1 year within the methadone clinic setting, but it can be longer if patients wish. Some people are on methadone for a long time, and this can just be part of their routine. The study of this intervention found that 74% of DART participants achieved an undetectable viral load within 6 months, compared to only 41% of HIV-positive people who attended the methadone clinic but didn't participate in DART. So 74% with an undetectable viral load compared to only 41% is a pretty huge difference. The fourth intervention is Project HEART, which stands for Helping Enhance Adherence to Antiretroviral Therapy. It's a tongue twister. This intervention includes a series of 5 individual or couple sessions, and it's delivered just before and just after initiation of antiretroviral therapy. And this is combined with 5 support calls in between the sessions, plus a 1.5-hour booster session at 6 months after the intervention ends. So there's a whole bunch of pieces here. The original study of this intervention found that 46% of participants had at least 90% adherence to their treatment regimens at 3 months after beginning the study, compared with only 28% of people with at least 90% adherence in the control arm. So 46% of Project HEART participants, compared to only 28% of control participants, had at least 90% adherence. The fifth intervention is called pager messaging. No, they missed the memo about acronyms, I think. So this one is only a 3-month intervention. Here, each patient receives a 2-way pager and a message schedule that's customized to their particular daily medication regimen. And pages include dose reminders, educational information, and adherence assessments. So there's a minimum of 3 daily pager messages for the first 2 months, and then the frequency gradually tapers off in the last month. So instead of paging all the time for 3 months and then it's just over, it's intended to taper off so that post-intervention, without any kind of paging, participants don't suddenly cease adherence because they don't have that pager constantly reminding them. A study of this intervention found that patients who had pager messaging were almost twice as likely as those who didn't to achieve an undetectable viral load during the intervention. The 6th intervention is called Partnership for Health. So this is different from a lot of the other ones. This is a clinic-based intervention, and it's really emphasizing the importance of the patient-provider relationship to promote patients' healthy behavior. It lasts 10 to 11 months, and it's based at an HIV primary care outpatient clinic. So at each clinic visit, the provider delivers a 3 to 5 minute brief counseling session with a focus on supporting medication adherence. And then there are medication adherence related posters placed around the clinic, and at least once a month patients are given brochures or other materials about adhering to treatment. So it's really changing the whole environment of the clinic to really support treatment adherence and also improve that patient-provider relationship. So at 11 to 18 months after beginning the Partnership for Health intervention, 86% of participants reported at least 95% medication adherence, which is really huge, compared to only 70% of participants in the control group. The 7th intervention is called peer support. So in this intervention, clinic patients who are HIV positive and currently on antiretroviral therapy serve as peers who provide medication-related social support through group meetings and weekly individual telephone calls over a 3-month period. So similar to how we talked about the patient navigators before, that peer support is often the way that that's framed, and it's a really important thing. This is very similar. So people who are already in the swing of things with antiretroviral therapy are serving as peers who can provide support to others who are really trying to get into the swing of it. So this happens over a 3-month period, and as you can see on the slide, it involves 6 twice monthly 1-hour group meetings and weekly phone calls, all these things. So in the original study, participants in the peer support arm were more than twice as likely as the control arm to report 100% adherence at 3 months after the start of the intervention. It's pretty amazing how peer support can work. All right, and finally, the 8th effective treatment adherence intervention is SMART Couples, which stands for Sharing Medical Adherence Responsibilities Together. So in this intervention, a nurse practitioner conducts 4 45 to 60-minute sessions each week for 5 weeks with serodiscordant couples, so one person is HIV positive and one person is HIV negative, to address medication adherence and safer sex behaviors by fostering active support for each partner from the other partner. So this intervention is intended not just to increase medication adherence, but also to improve the couple's relationship by increasing support, addressing sexual transmission concerns, and issues of sex and intimacy. The study of this intervention found that 3 months after the intervention was complete, 12% of the people who had been in the SMART Couples intervention reported taking all of their prescribed doses of medication within the appropriate time window at least 90% of the time. And in the comparison group, only 2% of people reported this adherence. It's a pretty dramatic shift, even though the numbers are relatively low. As we've talked about, adherence, especially perfect adherence, is really, really challenging. So depending on you might have noticed sometimes the percentage of people who are adherent is very high and sometimes it's very low, and a lot of that has to do with how it's measured and how perfect the adherence needs to be counted. So just a little note on that. Okay, so those are the 8 interventions. And we're getting close to the end of the webinar period anyway, so I have some closing thoughts, and then we'll hand it over to Sonia for a little bit to close up the webinar, and then we'll have some more time for Q&A at the end. So the closing thoughts are pretty simple. By linking people with HIV to high-quality medical care and assisting them in taking any of their medications properly, we're not only improving their health, which is very important, but we're also helping to prevent the spread of HIV to others, which is equally important. So that, simply put, is the reason that in a high-impact approach to HIV prevention, there's so much emphasis on linkage to care interventions, why we really want to emphasize active linkage, really helping people get the support that they need to medical care, but also to all the other resources out there that they really need. Make sure they have all of the knowledge and ability to access things that they need so that they can really make decisions that make the most sense for them. So with that, I will hand it over to Sonia, and she has a few more slides to go through before we move to the Q&A. Thanks.
Thank you so much, Shelley. So we'd love to just hear one more chat from you guys if you want to use your questions feature and just chat in what has inspired you in this webinar, or what's an idea that you're going to take away from today's webinar. You know, we really recognize, and we hear a lot from organizations that we're working with, that folks are anxious and concerned about this new emphasis in high-impact HIV prevention and the ways in which they are rethinking some of the HIV prevention programs that they're already implementing. So this is a great opportunity to think about how to apply some of what we've talked about today in your own organization, and how to make sure that the things that are being emphasized in high-impact HIV prevention continue to be what we focus on in our organizations and in our communities. So go ahead and use the questions feature again and just chat in any ideas that you're really taking away from this webinar, or things that you might really try to focus on in your own HIV prevention work. Also, if you do have other questions, feel free to chat them in that questions box, and we'll do our best to answer them. So we've gotten a number of questions about, I'm trying to sort of synthesize some of the themes that we're seeing, but we've gotten a number of questions about how to support linkage to care for clients who have been lost to care, or who once were connected but have now dropped out of care. And I don't think that there's any easy solution to how to even find folks who are lost to care. I think it's just often a lot of legwork in terms of exploring any contact information we have for people, and multiple follow-ups, and that continued engagement. There has been some great work done in both research studies and in program implementation around all the different ways to try to maintain engagement and maintain contact and communication with people over long periods of time. And I think that can be really helpful in terms of finding folks when they have dropped out of care. Also working with care providers, that's one of the things that's really being promoted in terms of active monitoring of success of linkage to care, and some of the, you know, whether it's via communication with the client or whether it's getting release of information forms to talk directly to providers, but systems that help us to track when people are missing appointments and dropping out of care, so that it's not 6 months or a year later that we're trying to re-engage people. But a lot of the interventions we've talked about, particularly the more intensive short-term interventions like ARTAS or CLEAR, can be used to re-engage people in care, as well as to help people link to care for the first time. And those interventions are all really oriented to they're very tailored approaches to working with people around their priorities and addressing their concerns around linkage to care. So I think that can be a really important place to start when we're trying to re-engage people in care. So that was a number of questions around working with re-engagement. Somebody asked a question about how do we get more information or trainings on some of the specific interventions, and I'll go ahead and actually put the next slide up, which is an answer to your question, which is, Shelley mentioned the effectiveinterventions.org website, which is the CDC's High Impact HIV Prevention information, and information on all of the effective behavioral interventions that the CDC is currently disseminating or diffusing in the community, training people on. So there are links in effectiveinterventions.org to all of the different interventions. So if you were interested in CLEAR or you're interested in ARTAS, you can go on, you can see the training calendar, when and where trainings are being offered. If you don't see a training offered in your community, go ahead and send them an email saying that you'd like to be trained in it. That's also part of how they determine when and where the trainings are going to be offered, is how many people are requesting them. Additional resources that are online, we have a website, an online resource library, and we will post the slides from today's webinar as well as the recording. We also have information sheets that were developed along with this whole series on high impact HIV prevention. Those will all be online. And the content of today's webinar, if you can show the next slide. The content of today's webinar is also available, sorry, one slide forward still. The content of today's webinar is also available as an online training, and so if there are folks that you think would benefit from hearing our conversation today who would like to do it more in a self-paced way, it's all available in our online resource library. The website is on your screen right now, and also we will send a follow-up email that will have a link to where the materials are, as well as an opportunity for you to give us some feedback on what you thought of today's webinar. Finally, on your screen you'll see the contact information if you want to get in touch with us about individualized capacity building. We did mention at the beginning that we're funded directly by the CDC to provide free support in capacity building, so we work individually with organizations. If you had specific questions about material that was covered today, or you're thinking about how to try to make some changes in the type of HIV prevention work that your organization is doing, or you have questions specific to some of the interventions we covered, please feel free to get in touch with us. We're more than happy to work with you individually. And finally, if you can just go back one slide, just to remind folks that this webinar is part of a series of 3 webinars on high-impact HIV prevention. If you missed the first webinar, the materials from that are online in our online resource library. The third part in this series is really focusing on high-impact HIV testing. So we're going to talk about the ways that high-impact HIV prevention is shaping a new approach to testing. We'll talk a bit about some of the effective testing interventions, like PCC, personal cognitive counseling, is one that's getting a lot of emphasis right now. And we'll also touch very, very briefly on some of the new testing algorithms that are being talked about. So please tune back in on July 11th, 3 weeks from today, for the third part in this series. We just have a couple more minutes, and I do want to open it up for other questions. So if anybody would like to ask a question live, you are welcome to click on your raise the hand icon. It's a little green box with a hand in it, I believe, and we can actually call on you and unmute you so that you can ask your question live if anybody would like to do that. Or you can use that questions box in the lower right-hand corner to type in any last remaining questions. We are happy to stay on the line to answer questions too beyond the end of our allotted webinar time. So we've got a couple more questions. Somebody asked about linkage to care strategies for working with teens and young adult populations. As far as I know, and I would love to hear from anyone on the line if you know otherwise, I don't know that there are specific linkage to care interventions that have been proven effective at this point that specifically target teens or young adults. So ARTAS and CLEAR, which are the two in a curriculum-based in a linkage to care interventions that are being talked about a lot right now. The original research included a wide range of clients in terms of client ages, in terms of mental health and substance use, in terms of ethnicity and geographic location, rural versus urban, but and did include teens and youth in some of the original research, and certainly has in some of the implementation that we've seen so far of both of those interventions. But I don't know of any specific young adult or teen focused curricula or interventions around linkage to care. So if anybody on the line knows otherwise, please chat that in and we will share that back out. I think we've addressed most of the questions that have come in so far. So curricula and information about the treatment adherence interventions is also on the effectiveinterventions.org website. There's more and more information being put up on there every day. High Impact HIV Prevention is still relatively new, and a lot of resources are still being developed and posted and publicized. So I think that's all the questions that have come in so far. We'll go ahead and stay on the line for another couple minutes. If there are additional questions, please feel free to click on your raise the hand icon or type them in your questions window. And we just really appreciate everybody joining us for today's webinar. Please feel free to contact us if there's individual capacity building that would be helpful to you. Also, feel free to check out the materials and resources affiliated with this webinar, as well as the whole High Impact HIV Prevention series, which are in our online resource library. So a big thank you also to Shelley Facente for her work on today's webinar. We'll be hearing from her again. She'll be back with us for the third part in this three-part series.
Thanks very much. It was great.
So if we're not seeing any more questions coming in, we will go ahead and close out today's webinar. Again, the slides and recording and information will all be available on our website probably by the end of today, and we'll send out a follow-up email to everybody who was officially enrolled or signed on for today's webinar with information about how to access those materials, as well as an opportunity to give us some thoughts about feedback on today's webinar. So thank you again for joining us. We're going to go ahead and officially close out the webinar if there are no other questions. And we look forward to being back online with you all on July 11th for the third part of this High Impact HIV Prevention series. So thank you again. We're going to officially close out now.